I'm really pleased to introduce our presenters for this session. We'll be speaking in order. I think Adam and then Lisa and Mark will be saving questions for the end. Please post them in the chat, just so that you know the chat pod that shows up on your screen is specific to this session. So your questions will be coming to me, and I'll be trying to keep track of them so I can pose them at the end. There will be some polling questions as we go through. We'll take a couple of minutes to answer those, but let me introduce our speakers first. Lisa Lefebvre completed a fellowship in addiction medicine at U of T in 2006. She's a diplomat of the American Board of Addiction Medicine and received her certificate of added competence in addiction medicine from CFPC in 2019, the inaugural year. She's certified by CCSAM, and she's a medical review officer as well. She chairs the CCSAM Education Committee. There's just so many things. I'm going to stop there. She is currently the Associate Medical Director at the OMA Physician Health Program, which is where she really brings this expertise, and we appreciate you being with us, Lisa. Adam Newman is a classmate and friend of mine. He practiced full-scope family medicine in Sioux Lookout in Kingston for 20 years before obtaining certification from the Canadian Association of Addiction Medicine in 2013. Since then, his practice has been focused on addiction medicine and harm reduction exclusively, with a primary focus on perinatal addictions and substance use. He's MRP for opioid-dependent infants rooming in with mothers at the Kingston Health Science Centre and the founding board chair of the Kingston House of Recovery for Women and Children. In 2010, he was admitted to Homewood in Guelph for opioid use disorder and was monitored under contract with the PHP. And he's here to speak to us about his experiences and share insights. I'm very grateful for that. And Dr. Mark Weiss has practiced addiction medicine for 20 years. He was previously medical director at Bellwood, chief of addiction medicine of Homewood, and currently is medical director for Renaissance, which provides residential addiction treatment care fully funded by the Ministry of Health. Dr. Weiss has a particular interest in the co-management of concurrent disorders, psychotherapy, and mindfulness in healing addiction. He's been a member of the PHP's Physician Advisory Panel and has significant experience in the assessment and treatment of addiction in safety-sensitive work. So thank you all, and thank you to our participants. Without further ado, Adam, I'm going to hand it over to you.
Adam, I think you're muted.
Yeah, sorry about that. Is the sound okay? Can you hear me all right? Yeah. So, Jennifer, do you mind putting up the first three polling questions that we had for the audience?
Sure. Brittany, can you go ahead with those? I'm going to read these, and I'll just mention that these questions and any of the questions that come up later are confidential. So question number one, we always like to know who we're talking to. Please select the option that fits you best. Physician, nurse, counselor, social worker, case manager is one grouping, administration professional, peer, or other. And if you can click on those, Brittany will be able to share the results on your screens. Brittany, are we good with our polls? Great, thank you. Okay, about 20% counselors, social worker, case managers, and close to equal proportions of physicians and nurses. Question number two, do you treat patients? Yes or no? I'm going to assume that pretty much everyone in this session is working directly with clients, patients. Well, since those percentages don't add up, maybe we have some some non-answers. Okay, but the majority clearly do. And question number three. If you do treat patients, which of the following groups do you treat? Veterinarians, pharmacists, physicians, nurses, and others. I know I find that the categories really interesting in terms of who's followed by which section, like dentists in one, veterinarians with physicians anyway. If you would answer that question, please.
Sorry, Jennifer, I just noticed I was trying to log my own answers, and I think it only accepts one answer, although I guess ideally you could answer as many as are applicable.
Ideally, you would. So if you can only answer one, I guess answer the one that represents the largest group that's appropriate to you. But that's a good pickup that may affect us in other sessions, actually, where people work in multiple settings. Okay. I don't know that I can see the bottom. I see pharmacists, one person who answered veterinarians. And I can't see the bottom of the replies in terms of physicians or nursing. So I think with that as background, Adam, is that good? We'll let you go ahead.
That's great. Thank you.
Thanks.
Hello, everyone. Thank you for joining us. So as Jennifer said, she and I were classmates, and I'm afraid that my appearance probably discloses more about how long ago that was than hers. But I'm gonna start off by introducing myself the way I do each week in the Caduceus group for health professionals with addictions who are mandated by their licensing college to attend a weekly accountability group. So everybody checks in one by one, and I usually am the last, and I say, my name's Adam Newman. I practice addiction medicine in Kingston, Ontario. I have been in recovery from opioid use disorder since July 7th, 2010. My current clean date is October 17th, 2018. So I do that very clearly not because I am seeking to derive therapeutic benefit from the group myself. I think everybody in the group is clear that I am a physician. I am acting as the physician, and I'm a co-facilitator with Jen Brunet, who's an addictions counselor. I do this because for the 5 years that I was monitored by the PHP for my opioid use disorder, I had the opportunity to be in 4 different Caduceus groups. And in one group, I had to leave because of practical issues and geography. I joined another group, and shortly after I was informed, I found out that the leader of the previous group, the facilitator, had actually relapsed and had been actively using while they were still facilitating our Caduceus group without disclosing this to anyone. And in fact, that person later became a member of the Caduceus group that I was then a member of. So I decided as I moved into practicing addiction medicine myself, which I formally did, opening my own practice in 2015, that I was going to, and I was going to use my experience as an addict in recovery to give me legitimacy, I thought, but I would have to be open and honest about how long and to what extent I was actually in recovery. And therefore, I don't usually say the whole thing about how I've been in recovery since 2010. I just mentioned my most recent clean date, and my clean date is actually more recent than the Caduceus group. I've been facilitating now for going on 5 years, and I actually, some of you may have picked up, October 17th, aside from being October 17th, 2018, aside from being the day that marijuana was legally available for recreational use in Canada, it is just a few days away, and I will be, with luck and good fortune, I'll be celebrating 2 years clean. So I had to go through the experience of disclosing to the Caduceus group that I was facilitating that I had relapsed. I was not intoxicated at the time. It was, luckily for me, it was a single-use relapse. I didn't continue using. I wasn't impaired, but I felt reluctantly, and after a fair bit of hemming and hawing, that I needed to disclose this to the group. So just like addicts often say that addiction is the only disease that tells you that you don't have a disease, when I present on addiction topics to residents and medical students at Queen's University, I like to use my own little corollary, which is addiction medicine is the only specialty for which having the disease itself is considered a qualification. And I just want to be clear, I don't think it's necessary, and it's certainly not sufficient. But in my case, I can attest that I really didn't understand addiction until I had experienced it myself. And by that time, I'd already been working for 10 years at the Street Health Methadone Clinic, prescribing opioid agonist therapy. In those days, we had only just started using buprenorphine. And this was a street front, low threshold clinic. All of the patients that I saw there would have had ACE scores that were off the charts. We didn't actually then do ACE scores formally, but they all had experienced child sexual abuse, violence, neglect, extreme poverty, institutionalizations, or more often, some combination of all of those. I had read In the Realm of Hungry Ghosts, and I was struck by Gabor Mate insisting that we shouldn't ask why the addiction, we should ask instead why the pain. So even though I was actually taking Percocets in between patients that I was prescribing methadone to, I was occasionally pocketing a bottle of morphine elixir or unused OxyContins that a family practice patient would bring back because they hadn't used and didn't know what to do with them. Those were the bad old days. I was going to say good old days, but the bad old days when pharma reps actually gave samples of tramadol to physicians' offices, and our office went through them very quickly. Nobody actually noticed. I had actually never experienced trauma on the scale they had, or really even at all. I'd be a bit embarrassed to do my own ACE score, but I think the only thing I experienced as a child that would even rank would be the divorce of my parents when I was 7 years old. It was not a particularly rancorous or acrimonious divorce. So it wasn't until I had to admit what I was doing and had to stop and realize that I couldn't, that it finally occurred to me that I actually was experiencing addiction, the very thing that I supposedly had been treating these patients for. And understanding the difference between being a methadone prescriber and being an addiction medicine physician was something that I also appreciated at that time. And I'll talk a little bit later about why I'd opted to go into addiction medicine. So I will never forget the day that I sat in the office of a psychiatrist, confessing to him that my life was in a mess. I listened as he dialed the PHP and told him that I needed help, and then handed the receiver over to me. And the rest is history for me. I was referred to Ewan McKenzie, who was the only physician in Kingston at the time who was practicing addiction medicine. And I'm forever grateful for that referral, and I'm forever grateful to Ewan. Because I walked into his office and I just vomited out this total train wreck that my life was in. And he didn't really seem fazed. It was an everyday occurrence. It was the stuff that he heard every day from his patients, who he was in a private practice. This was not a street front. These were patients who actually looked socioeconomically similar to me. They were upper middle class professionals sometimes, but he had heard, actually, he disclosed to me, probably every addiction physician discloses this to the patients at some time, I've heard worse. He was also able to calmly discuss my options, and I was relieved to hear that I did have options. And it was his willingness to disclose his own successful battle with addiction and recovery that really struck me. And at that time, he was going on 10 years sober, and he has maintained that. I immediately felt I could let down my defenses. He wasn't going to be judgmental toward me and my behavior. And again, it suggested that there was hope for me. And that was a large part of what gave me motivation to volunteer to speak on this panel today. Because I felt that his ability, a normal, quote unquote, normal functioning professional who was fulfilling his role as an addiction physician, was able to disclose that he had had an addiction. And that's partly why I offered myself to be an example of somebody today who has been through the ringer. So I started attending 12-step meetings. And I remember when Ewan really made me pay attention to the words of step 2, which is, we came to believe that a power greater than ourselves could restore us to sanity. And that was not coincidentally when he told me that I had to go to Homewood, which of course I was reluctant to do. But it was my first experience of a higher power, really. And that was lucky because I was then and still am a committed agnostic. I was going to say atheist, but Ewan disputes that. He tells me I can't be an atheist and be spiritual. I don't know about that. But it was my first step towards understanding that spirituality did not mean religion. And that is something I really hadn't appreciated before, just as I hadn't appreciated that I was suffering from addiction. And I think that my appreciation then of the difference between spirituality and religion is probably the most important thing that I learned in the whole entire painful experience of addiction and recovery. I didn't actually get clean until the first day I arrived at Homewood, a month after meeting Ewan. I still relapsed a couple of times after I'd signed a contract with the PHP and had returned to Kingston, but before I'd returned to work. But I started on the road of a recovery plan. I started attending daily Narcotics Anonymous meetings, weekly appointments with Ewan. I had a monthly check-in with the monitor assigned to me by the PHP. And Ewan prescribed a regimen of medications that then did and still includes naltrexone, which I fortunately had an immediate therapeutic response to, and I have opted not to go off, not to stop taking. I was also subject to random urine drug screening. And I returned to work 3 months after my admission to Homewood, and I've worked continuously ever since. I returned to work actually at Street Health, where I had been a methadone prescriber, but then I was only as a hepatitis C treating physician in their hepatitis clinic for marginalized people who didn't make it to the hospital specialist clinics. I also began, well, I had already, but I became a referral point for obstetrical care for anyone who became pregnant after starting OAT. And that partly led to my current my current focus on perinatal addiction. And I voluntarily agreed to surrender my ability to prescribe narcotics, largely in response to valid complaints by former colleagues from the family practice I had worked at. This led to an investigation by the CPSO, and I satisfied the CPSO by quote unquote voluntarily giving up my ability to prescribe narcotics, although I understood that it was something I had to do, and it really was a relief. I didn't apply for that condition to be lifted or conversely to get privileges to prescribe narcotics again for 2 years. And by then I had attended the college's opioid prescribing course, and I'd had a formal audit by the college. And I only did it then because I had decided then that I wanted to train in addiction medicine with a view to actually practicing it myself. So this was a couple of years after being back in Kingston and being clean. And I could see that it was going to be difficult to practice addiction medicine without also being able to prescribe OAT. So I got my narcotic prescribing privileges back. I spent a year reading ASAM's Principles of Addiction Medicine. I read everything else I could get my hands on. I applied to do an unpaid and part-time preceptorship at CAMH in the addiction medicine outpatient clinic. I got to spend 3 weeks at the FUR unit at BC Women and Children's Hospital, where I was able to observe Ron Abrahams and the team that looked after opioid addicted and otherwise addicted women from the downtown east side who were rooming in with their babies. And then I wrote the ISAM certification exam in October 2013. And I'm sure I think for all of us, for all physicians, part of my reason for wanting to write an exam and get a diploma was because I felt like an imposter. I knew that my decision to go into addiction medicine was at least in part a kind of reaction formation defense. I was seeking to atone for bad behavior that I had engaged in as a lowly addict, and to redeem myself by taking on the identity of a healer. And that certainly was possible after satisfying the objective requirements of an overseeing body that I had learned enough about addiction medicine. Because I did not feel that just having been an addict meant that I could be an addiction physician. It didn't. But really, I wanted to study addiction medicine because I had never encountered a topic. When I really did reading about it, because up to that point, my only experience with addiction were the injection drug users at Street Health. But when I read about it, I realized that it was just the most mysterious and fascinating and protean subject in medicine, and I was sure that I could happily spend the rest of my career focusing on it. So the patients that I had been judging to be totally different from me and hopelessly lost and totally hopeless, now I could see in them, because I kept seeing them treating their hepatitis, I saw in them something that I recognized in myself, and I could empathize with them because I had experienced my own version of rock bottom, which thankfully wasn't as severe as theirs. I had lost the ability not to use a drug that something deep in my brain told me was vital and even approaching holy. Again, I realized at that point that though I didn't consider myself religious or spiritual, I acted towards this obsession in my life as though it were something that I believed in fervently. And it didn't matter how much my prefrontal cortex told me, stop it, don't do it, it's not a good idea. That my prefrontal cortex or super ego, if you're Freudian. But I realized that I also learned to use my drug of choice, which in addiction we often refer in 12-step circles, we refer to as our drug of no choice, in response to very different triggers in the patients at Street Health, but it was centrally wired deep within me. So I came to appreciate that the trauma and the social marginalization and neglect and abuse that they had all suffered weren't the cause of addiction, because I hadn't suffered those things and I had addiction. They were additional burdens that those people had to struggle with, on top of fighting with this deadly kind of spiritual quicksand that each of us had fallen into. So Norman Bethune, my hero, said 100 years ago, there's a rich man's tuberculosis and a poor man's tuberculosis. The rich man recovers, the poor man dies. And just, again, especially having heard the plenary speaker this morning, I'm fully aware how much I have benefited from white male privilege. There's no question of that. I didn't ask for it, and I hope I haven't played a part in setting it up or propping it up or perpetuating it, but I certainly have benefited. As well, I was lucky enough not to have been poor and abused or neglected and hungry as a child. I was practicing a privileged and well-paid profession that luckily at this day and age had evolved enough to become enlightened and accepting of addiction as an illness, thanks in large part to a recovering addict who was one of the founders of the PHP over 20 years ago. But they were able to treat members of the profession with addiction, with compassion and support and empathy, because they realized that that was much more likely to restore them to being acceptable, responsible, and productive members of society than shame and discrimination and penalization, penalty. So I can't pretend that I didn't sometimes chafe at the constraints of my monitoring contract. I mean, can you imagine 5 years without eating a poppy seed bagel? But the professionals that I encountered at the PHP, whether or not they were in recovery themselves, seemed to me to be genuinely committed to supporting me and aiding my success. And again, as we say in 12 steps, they believed in me until I could believe in myself. So thank you very much for listening. And back over to you, Jen.
Thanks. I think that segues perfectly. Lisa, we'll hand over to you.
Do you mind just asking that final poll question?
Thank you. The final question, and just a reminder that all answers are confidential. I don't see the question, but I think the question was whether any of our participants are in recovery from addiction or substance use disorder. Ourselves. And thank you for making us confront that question for our own selves, whatever it means to us. Even if you don't feel comfortable answering that, knowing it's confidential. And thank you so much, Adam. It's not a small proportion, and I would guess that it's, despite confidentiality, perhaps an underrepresentation of those of us in attendance. Lisa, over to you.
Thanks, Jen, and thanks, Adam. It's always so inspiring to hear someone's story, especially someone as esteemed as Adam, and for what he brings and provides to all of our patients through his recovery and his experience. So thanks, Adam, for that. All right, so bear with me as I get used to this different platform. So I'm Lisa Lefebvre. It's so nice to have you all here. I wish I could see your faces and that we could interact a little bit more, but I'm so excited that we actually still get to do this, and we get to do it online with several of my favorite colleagues here with me. So I work at the Physician Health Program. It's part of the OMA, and I'm going to quickly take you through some sort of high-level background information with respect to physicians and substance use disorders. So I'm just going to quickly go through my financial disclosures. So I am employed by the OMA, and so get salary support from them. And of course, they're in kind supporting this program by allowing me to be here this morning. And I do also have another conflict to disclose in that I have been on the advisory board for Indivior, and I've also done some work both for the Ontario Pharmacists Association as well as the Canadian Pharmacy Association, educational work for them. All right, and the presentation has been peer reviewed by my colleagues who are here presenting with me this morning. Sorry, just struggling here with the slides. All right, so just to review what Mark and I are going to try to accomplish in the very short time that we have with you, I'm going to go through some stats related to substance use disorders among physicians and look at this current standard of practice. And then Mark is going to look sort of more from the treater perspective at the unique relational aspects of having a health professional as your patient, and also a corollary to that being a health professional patient. It's a big part of what we do. So in terms of how common are substance use disorders in physicians, this little cartoon may give you a little bit of a clue. So prevalence has increased a little bit in recent surveys, but we used to say it's about 1 out of 10. Most recent survey data from 2015, it's creeped up a little bit to 15%. Of course, we look at those trends over many years. We don't know if that is something that's going to continue or if that's a blip. But it's not so different from the rest of the general population. And I think sometimes that surprises our colleagues and the public, that they think that for some reason we may be sort of immune to the problems that affect our friends, family, other people. That is not the case. And if we look at suicide data, which is not the topic that we're really focusing on today, you really see that our prevalence is significantly higher, and Mark will touch a little bit on that. But in terms of substances, we're not immune to substance use disorder just as the rest of the population is. And actually, if you look at the whole population of physicians, the substances that are used, that are the primary problematic substances, are similar. So alcohol, then opioids, stimulants, and a minority of people would be injecting. And that's the case for the larger population in Canada and across North America and sort of the Western world as well. So if we look a little deeper, though, there are some interesting subpopulations that we can learn from. And these subpopulations have different sort of epidemiology in terms of substances used and slightly higher incidence of substance use disorder. And this is really by virtue of their access to substances. So if we look at anesthesia as one of these populations that is actually quite well studied, anesthesia should be commended for the fact that they recognize that this is a risk to their particular specialty decades ago. And they've been proactive at educating residents and practicing physicians with respect to this unique risk due to the access that their profession has to a variety of medications. So if we look at anesthesia and what substances may be problematic in that subpopulation, we do see that opioids is significantly like their primary substance of concern. And that's simply because there's access to it in the hospital. There is a higher proportion of injection drug use. Again, same story. They have access to injectable drugs and the equipment used in injection relatively easily from their workplace. And you'd sort of be surprised at the varying degrees with which narcotics are managed in different hospitals across the country. It's a bit of the Wild West. There are some very high level sort of recommendations, but that's not a very well developed area of medicine and nursing, unfortunately, at the present time, which is a challenge for some folks when they want to go back to those environments. And so if we look within the opioids, fentanyl and sufentanil top the list, the most potent of the opioids. I'll just say one thing about other substances with respect to access in the hospital, and that is that there's a little bit sort of creeping up of access to other substances, including things like propofol and some of the inhalational anesthetics, but we really don't have great data on that, but we're sort of keeping an eye on propofol in particular. Very deadly drug because the toxicity window is super narrow, and you're sort of walking a knife edge between having an effect, which is sort of relaxing and dissociative, and unfortunately coming to serious harm, including overdose and injury as well. So just to look at a little bit of the other data related to anesthesia, aside from the sort of breakdown in terms of substances, trying to get a sense of what the increased risk for this population is, we do see in several publications a higher risk of drug-related death with anesthesia compared with, for example, internal medicine 3 times. If you look at who is in treatment programs that see a lot of physicians and who is in physician health programs, anesthesia compared to its relative epidemiological numbers is overrepresented in both. And so some folks with much more sophisticated math skills than myself have calculated a relative risk ratio or relative risk for substance use disorder with respect to anesthesia as 2.7 times that of the average risk of the physician cohort overall. So recognizing we're going very quickly through things, and we'll take questions for sure at the end. I'm going to turn a little bit to what Adam touched on this morning in his very eloquent presentation, which is physician health programs. Like how did they come to be, and where are we at now versus where we were, before I entered the field of medicine decades ago, where this was really approached in a different way. So if we go back sort of to middle of the last century, we're looking at an emergence of looking across the board, not just with respect to physicians, but looking at addiction as an illness, something that's treatable versus previously sort of a moral disease and something that, is absolutely terrible and needs to be punished. So previously, before the physician health programs sort of came on the scene, sort of 80s, 90s, physicians with a substance problem were channeled through the disciplinary route as if they had done something absolutely terrible and often had to leave the profession. There was often no way for them to come back. There was no sort of pathway, there was no sort of roadmap, and there was this huge stigma related to them being morally reprehensible. And as that started to change into the general approach to addiction, there was a group of physicians within the profession that said, well, can we treat our own colleagues, in a different way? Can we allow them to safely come back to practice? Treat this as an illness like any other, that once it's treated in remission, the person should be fully functional. And so they set out to set up these programs that were initially called sort of like impaired physician assistance kind of programs, very much focused on addiction back then and not so much on mental health as we do both today. And there were 2 goals, and there still are 2 goals, which is to help the physician become well, to save their life, to save their career, but also to protect the public as we look at having them go back to work, and carefully balancing those 2 things, and particularly carefully balancing also issues of confidentiality with respect to physicians and their health information, as well as the accountability that's required of them as safety sensitive workers. And I'll sort of touch on what we mean by safety sensitive workers. So we're still continuing to balance this today. And it's different in every province. As some of you may have seen, if you're physicians that have moved from province to province, the colleges ask very different questions and get involved in your health to varying degrees across the province, and it's not uniform. So it's still evolving. So if we look at who are safety sensitive workers, this I've taken from the American Society of Addiction Medicine criteria book in their safety sensitive worker chapter. So it's a bit of a case-by-case definition with respect to the profession that you're looking at. So these are the underlying principles with respect to what is safety sensitive work. So a safety sensitive worker would have some sort of responsibility for the safety of the public in some way. And so healthcare professionals definitely fall under this category, but there are many other workers that fall under this as well. So some examples that I've just listed here, pilots are a big one, and they've developed programs sort of in tandem with the physician health programs over the decades that are some of the most developed with respect to treatment and monitoring of substance use disorders and mental health disorders. But we also have pipeline workers, people who are working in oil and gas, nuclear operators. There's quite an extensive list. And if you come across sort of a new profession and you're trying to figure out, which is probably not going to be something you have to do, usually the employer has figured this out, but some of the things to think about with respect to the responsibility for the safety of a population. How big is that population? What is the depth of the effect of a potentially impaired worker on the well-being of that population? And what is the extent to which society puts trust in this worker's occupation? So we also look at things like police and whatnot, potentially fall into that category as well.
Lisa, in the interest of getting to Mark, I'm going to give you a 3-minute warning, okay?
Okay, very good. So if we look quickly at CCSAM criteria in terms of the treatment of health professionals, there are some guiding principles there with respect to what is sort of considered the standard of care. Some of them are psychotherapeutic, sort of knowing some of the common defense mechanisms, as they call them, and personality traits of the cohort, which have actually been quite well described in psychological testing. And others are knowing what the work environment is about, what the regulatory sort of oversight or monitoring programs that that professional may be subject to when they go back to work involve, and sort of preparing them well for that. As I won't read all through the rest of that for the sake of time. If we look at formal monitoring programs, really the principles are good evaluation to understand what's going on with that individual, make diagnoses, get them the right treatment, ideally with other health professionals, but not always. And then intensive monitoring with respect to treatment compliance and toxicology. And there are other programs out there aside from the pilots and the physicians. You know, their drug treatment court is a very similar model, which has good outcomes as compared to, taking the disciplinary route like we used to do for physicians and sending people to jail. So there's some good evidence around drug treatment court, which is a bit analogous. In terms of monitoring programs and what research has been done with respect to physician health programs, there's quite a few studies that were done, multiple PHPs in the States, published in the early to mid 2000s. And this one is very sort of key in terms of when I'm describing monitoring to someone and how it could be beneficial to them, not just to meet their accountability requirements, but actually to change their prognosis. So they looked at the physicians monitored for the standard 5 years compared and their relapse rates compared to the general population, who were actually only studied for 6 months. So if you kind of blow this out, you can imagine after 5 years that 40 to 60% success rate for the general population, unfortunately, is going to dwindle to significantly less than that. Whereas with the intensive treatment and monitoring, we have relapse rates of less than sort of 22% for the physician cohorts in those various PHPs. They studied 16 PHPs. And then quickly, if we look at the Ontario PHP, before my time, but they looked at the first 100 monitored for what was then called substance dependence. 71% had no detected relapse, and 17% had a relapse, were still able to finish the 5 years, sort of early detection, early intervention, things went well after that. And then unfortunately, a minority did either get lost to follow-up or they had a more extensive relapse. And I'll just touch briefly on OAT, because this is always a sort of hot topic, or often with respect to health professionals and monitoring and treatment and whatnot. So at the moment, at least in the PHP, we take a case-by-case approach, trying to balance the sort of importance of having our folks have access to the standard of care, but also looking at some of the concerns that have been raised in some of the studies of OAT with respect to cognitive impairment. And unfortunately, there's no great protocol to definitively sort of test for this. They have done neuropsych testing and determined that methadone is significantly more impairing than buprenorphine, for example. So we take that into account as well. And it's really a case-by-case basis. In some other jurisdictions, it's an absolute no-go. So some of the American states still would absolutely not allow it. But there's more and more every year that are taking a case-by-case approach, which is encouraging. So to summarize, there is evidence-based effective treatment available for physicians and other safety-sensitive workers. The standard of care at the moment is ongoing monitoring in the sort of chronic disease model, and the rates of recovery, as we saw in the monitored physicians, are superior to those of the general population. So some papers have been written saying, why can't we bring this type of contingency management, intensive case management model to the general population? It's very resource intensive, but honestly, I think our general patients deserve more of a structured approach to help them reach the rates that the physicians can reach in terms of their success. So I'll stop there and turn it over to either Jen or Mark, however you want to do it from here. Thanks, everyone. I hope I didn't speak too quickly.
we're going to head to Mark, and I'll just say that although we're supposed to end at 10:30, if we stay on for an extra 5 minutes or so for questions, I know that won't be quite enough, but everyone will need a quick break before next session. So, Mark.
Thanks, Dan.
Okay. Can you see my slides?
Yep.
Okay, great. Well, thank you. It's a pleasure to be here. I'm going to try to get through this in about 10 minutes so that we have 10 minutes for questions. I'm Mark Weiss. I'm a medical director at Renaissance, and I have no disclosures or biases to disclose. My slides are rather rudimentary, but they're more or less to keep me on track. I have my primary area of I think focus is addressing, at least at this time, is providing care to physicians with substance use disorders. Although, and I'm going to reference physicians, but I've provided quite a bit of care in my past to nurses as well. And so I think for the most part, you can translate any of my comments that I use the term physician you can translate that over to nursing. I think everything is cross-applicable. So when we speak about why physicians present, there's at least one really significant and interesting difference between most of the patients that I see. Physicians may report themselves. They may knock on our door, call our office, ask for an appointment, and recognize that they have a problem with a substance and need help. There may be family that pressures them into coming to see us. But where the assessments are often different, and this consists of a large part of what I do with physicians, is when there is an occupational incident that occurs. What do I mean by that? I mean by a physician or a nurse who is reported by either another patient or other employees or colleagues to have had an odor of alcohol on their breath. There may be allegations or assertions of opiate misappropriation, or there may be behavior like slurred speech or disinhibited behavior that suggests that someone was intoxicated. And when a patient or a healthcare professional acknowledges there's an issue, that's relatively easier to deal with. The challenge, and this happens not infrequently, is that the healthcare professional who comes to see me often reports that there is nothing wrong, that the history or the concerns provided are for varied reasons invalid, and they are perfectly fine and don't require treatment or monitoring. The reports that one gets and one has to deal with as a physician who provides care to healthcare professionals, is that at times the reports that I get are very credible. And it can be really tricky trying to navigate that, because in the normal course of our work, we accept what the patient tells us generally in terms of what substance that is problematic to them and the details of the use and the impact it has on their lives. And it is different in this case, and I'm going to touch on what I think is the core to trying to navigate that issue and obtain a fuller disclosure from a healthcare professional, and I'll touch on that in my next slide. But I find to this date, they have always been challenging, and those continue, at least for me, to be the most challenging areas or where there is quite a conflict between what the client tells me is going on for them and what the reports that I get tell me might be going on. I think to help physicians, we really need to understand, and healthcare professionals, we need to understand the unique stressors that they experience. I'm not going to have time to address this in 10 minutes, but I am going to give you an article that I think was really helpful. And I read the article and I learned something about myself in reading this article. It was published in the Canadian Journal of Ophthalmology in June of 2020. It's entitled Beyond Burnout, Looking Deeply into Physician Distress. That said, I think the factors that they discuss are very applicable to nursing as well. And I'm just going to touch on, there is the reference, and I'll provide a copy of my slides to anybody that wants it, so you have the references. I'm just going to touch on the major issues that they discuss. So there are systemic issues that contribute to distress: the medical culture that we train in and the medical culture that we work in, the workplace environment itself that can contribute to burnout, our healthcare system. And I'll just point out, surgeons could be asked to start working weekends to clear COVID-19 backlog. They already have intense workloads. I can only imagine what that thought would feel like to some surgeons if they had to work 7 days a week. Interpersonal factors, empathic distress. So empathic distress refers to the idea that I have the empathy that I have for my patients, and the feelings that that empathy evoke within me cause me to dysregulate and cause me to experience distress. So that is what they refer to as empathic distress, and there's a good discussion on that. Moral suffering, the idea that I might be asked, for example, to discharge a patient from hospital and feel pressured to do so for any number of different reasons, knowing that this person will not get adequate or ideal care in the community. And that is what they refer to as moral suffering, and a significant cause of distress in some physician groups. I think that is just as true for nursing. Bullying and marginalization, unfortunately, continues. Unhealthy perfectionism. So perfectionism perhaps has allowed us to graduate from our varied trainings, but taken to an extreme, perfectionism can also create great stress. The need to always get it right, perhaps unreasonable expectations that we set upon ourselves and upon our colleagues and the system. Pathologic altruism, the idea that I need to care for the world. I need to care for everybody. It's my responsibility and I own it. Can also be a cause of distress. Self-recrimination, blaming oneself for the negative outcomes that we see. And then the pitfalls of success, which is even when we succeed, there can be a downside in that, in the sense that we can feel entitled. And that sense of entitlement can translate into unreasonable expectations of self, unreasonable expectations of the system, and unreasonable expectations of our colleagues and perhaps our patients. And that can lead to dysfunction and stress. Why do I raise this in the context of substance use? Because these issues are almost universally present in the individuals that I care for. And they need to be addressed in the recovery process, because if we don't address them and somebody goes back to work and these continue to play out as sources of stress, they create risk for relapse. So this is a template by which we can learn to know what to ask for. Where do we go when we're trying to figure out what are the issues this person needs to address in returning to work? And this, in a sense, outlines some of the subjects we need to explore with our patients. Many of you, well, I had a poll question, and it's not quite working the way I'd like it to work. So, but the question would be, or I think perhaps the point is that the occupations that we work in nursing and as physicians, creates significant stress. And I think that is highlighted by the fact that at least in the article, the Canadian Journal of Ophthalmology article that I referred to, published in June of 2020, it stated that male physicians have a suicide rate that's 70% higher than men in the general population. Female physicians have a suicide rate over 250% higher than women in the general population. I've not looked at the primary data myself, but that was quoted in that article, which I took to be reputable. And then Joy Albuquerque, who is the medical director of the PHP, and if you look at CMAJ 2019, I provided you the reference for that as well. male physicians are 40% more likely to die by suicide, and the risk to female physicians is more than doubled. What does that tell me? It tells me that something about the character of us as healthcare professionals that cause us to go into these professions, and the nature of the environment in which we train and the nature of the environment in which we work somehow conspire to create substantial stress. It's a marker of the danger, perhaps, that goes along with being a healthcare professional. And it's not insignificant. If you look at data on nurses, female nurse suicides were significantly higher. And male nurse as well, the data showed a significant increase in male nurse suicides versus the general population. I've given you the reference for that, and I'll let you refer to that on your own if you want more detail. What are some of the dynamics? Jennifer, how am I doing for time?
Not great, but it's not your fault. We crammed too much in, so.
All right. I will just touch on this because I actually think this one slide is important, and then I will stop.
Thanks.
Treatment issues to consider. What do I do when I have a healthcare professional in front of me? I put aside, I have a template that I use when I see a patient with addiction, with an intake assessment that I use for patients with addiction. And I generally try to take my notes as I go along while I see the patient. With a healthcare professional, I actually put that aside. And I spend my first session simply trying to address shame, to build rapport, and to send the message to them that you are not alone and I will support you through this process. We'll go through this together. And I try to build the idea of a team. And one of the key reasons I do that is because shame and fear translates to non-disclosure. And if you remember, I suggested to you that I get many cases that come to me where there is conflict between incident reports in the workplace and the patients claim that these issues have never happened or they're not valid. And when that happens, almost always, it's associated with shame and fear of occupational consequences. And if I can address that, if I can put it on the table and discuss it up front, I can move to non-disclosure and get a better sense of what is going on. That in itself is a bit of an art. And I could probably spend 30 minutes just talking about how one does that. The other thing I do is I assess safety. Which I think is really core. So what is the risk to self-harm? Remember, physicians and nurses have higher suicide rates. And so they may not disclose it, and they're often not willing to be vulnerable or tell us at the initial phase what's going on for them. So if that's true, I try to really assess what is the risk to them. The other piece is to assess the risk of professional harm, which means if this person goes back to work tomorrow or this afternoon to complete their night shift after telling me what they've told me, what is the risk? And what is our obligation as healthcare professionals in terms of reporting where we believe that there is risk to patient care? I'm not going to address that here. I obviously don't have time, but in the question and answer session, if we have time for questions, I do have some slides that discuss what we should do in those cases. And then they're often overwhelmed, and so I really spend time trying to create an agenda and cultivating the idea that we can only deal with this one step at a time. I will be with you. I try to see them more frequently and reassure them that if we work through this one step at a time, that the vast majority of healthcare professionals who go through the treatment process actually get better and go back to work and lead productive lives. So I'll stop there and then switch over to questions.
Thank you, Mark and Lisa and Adam. I apologize for creating a session where we tried to cram in so much that I think is raising more questions than you could possibly answer in this time. I have a feeling this is a topic that people may want to chat with you about, and you can use that chat in the lobby function, and perhaps this is something we want to take on at a larger level in terms of an interest group. Mark, thank you for reminding us that we always need to be thinking about safety and those high risks of suicide. One of the questions that's come up on the chat is, how do we look after healthcare providers who live in smaller communities? I think it's not only smaller communities. I think it's our communities of practice in terms of our groups and our hospitals as well. Could any of you, Lisa or Mark in particular, sort of address quickly what kinds of options there may be for people who don't have access to treating professionals or who are worried about disclosure and loss of privacy in their communities?
That's such a tough one. I wonder actually if I don't want to put Adam on the spot, but he actually practices in a smaller place than either Mark or I. I mean, I can tell you it is a challenge, and we try to help our folks problem solve sort of their level of comfort with disclosure. Some people are very open and it's actually not an issue. They've encountered the same issue as they are a health provider, for their small community. There are issues there with respect to their own privacy aside from their health information. But Adam, what are your thoughts? Because you deal with that probably more frequently than we do.
Yeah, well, to anyone who hasn't lived in Toronto, Kingston is a small town, but
sorry.
It's almost universally an issue when I encounter a health professional, really anybody. But when I suggest that they begin attending 12-step meetings, I can't. I might see my patients, my clients, people that I work with, people that I have worked with as a prison guard. I mean, there's lots of reasons why people are fearful of their anonymity being broken. And I mean, that was just something that I just had to get over. I mean, I maybe was a little bit pathologically willing to disclose my addiction. But again, as I said, I think it's bit by bit part of the reason that we are here now and we're able to talk about physicians with addictions and nurses with addictions being treated humanely and as if they have a disease is because people like Michael Kaufman 20 years ago was open and honest about the fact that he was recovering from addiction. And it's by accumulating these examples of people who can be responsible physicians, responsible nurses, responsible and effective PCAs and social workers and dentists, even though they have an addiction, that hopefully that shame will diminish. But there's no easy way around it.
I guess the other thing I would say is, maybe in light of what we've learned through COVID about providing virtual care, that perhaps we don't have to have those practitioners situated within each community and force people to get there in person. So why can't we use this kind of technology to access people the care that they need wherever they may be sitting? Right?
And there's also a lot of groups online. A lot of my folks are attending their same AA or NA or whatever group, but it's all moved online, some of them. And some people like that and some people don't. Some people like to go in person, but at least it gives the option to attend something virtual.
One of the questions that came up was whether there's any literature about professionals treating like professionals. So, for example, and I know we on this panel are a group of physicians, but we have nurses and social workers and others in attendance. So is there any research that you know about that speaks to social workers working with social workers, for example, nurses with nurses? And I say that recognizing that, typically it's physicians who are doing the prescribing, but there's so much more than pharmacotherapy that's important here, obviously.
There is no literature that actually that I know of that addresses like professional treating like professional. There is an article. So if somebody wants my slides, there was, and I didn't get to the slide on it, but there was a 2016 publication in the British Medical Journal, which was entitled, "Just So You Know, the Patient is Staff. Healthcare professionals' perceptions of caring for other healthcare professional patients." And it's an interesting read, and I can send that reference out to people. It talks about what they did was they polled various physicians in terms of what was it like for them to treat another healthcare professional, and they tried to group the responses. And it's an interesting read in terms of how they went about it. And it provides some information in terms of how we feel. But I think, but there's no actual research that I know of that's actually being done on the subject.
I think, you know, your answer really makes me reflect on how challenging it is, even in general care, not specifically the area of substance use disorders, to care for our colleagues who are physicians. And so I'm wondering about boundaries, and Adam, I guess I'm wondering in particular, but for everyone as well, your thoughts about, as a physician and as someone with an experience of a substance use disorder, how do you balance the professional role and your empathy with boundaries in care?
Hi, yeah, that's a good question, and as you said, I don't think it's any different than if you see a physician colleague for hemorrhoids or something embarrassing and stigmatized that doesn't deal with addiction. It's difficult, and it's incumbent upon us, the treating professional, to convey that we are maintaining a boundary and that we're respectful and that we never breach confidentiality. I don't greet people in the hallways of a hospital who I know as patients unless they greet me first, because I'm aware that they think, well, how am I going to explain how I know you? And I think that I referred to reaction formation. I've observed that among physicians who I have treated, and even my relationship to Ewan, who was my treating physician, there was a real desire to befriend him, to try to cross that boundary, to try to to be special to him and to stand out. And I think that's a normal reaction among patients. And I think it's part of the psychotherapeutic process too.
It's interesting. One of the most basic ways in which boundaries sometimes present is the physician who wants to call me Mark as opposed to Dr. Weiss, and that issue. And but it's a challenge in terms of most of my patients refer to me as Dr. Weiss, and it's not that I'm attached to that title. I'm not at all. All of my staff call me by my first name, but I refer to them as doctor, and they refer to me as doctor, and I call them by their first name, and they refer to me as doctor. And I don't know that there's an absolute right or wrong answer. And in some cases, I actually allow that first name basis, and in some cases, I might actually say to a patient, I might ask to be addressed as doctor, or I might actually have that conversation with them as to how would they like to address me, and how would they feel, how would they like me to address them. So depending, but it's a simple a shift in terms of them wanting to be a colleague and a patient versus a patient. And how do we, and that's just one simple, very basic example of, I think, how it plays out sometimes.
Thank you, everybody. I apologize for having to wrap up everybody. It's a short break before we get on to our next sessions. Lisa and Mark have shared their emails. I will leave it up to you guys to continue this conversation. Please remember to complete your evaluations for this session. Stretch your legs, get some water, don't over-caffeinate, and I'll see you in another few minutes. Bye for now.
Thanks, Jennifer. Bye, guys.
Thank you.
Jennifer.